All right, everybody, we're going to go ahead and get started. I know you guys had a week off, and see most of you have caught up on your quizzes and things like that. So just continue to do that. Like I said, this is chapter 16, childbirth. After this, we have pediatrics, geriatrics, EMS operations, and incident management. So not a whole lot left to go. Okay, so let's like I said, try to get there, push to the end, and make sure we're all trying to get caught up. We'll have a little bit of time there at the end for you guys to do that, and then we'll talk about our boot camp and see what works for everybody and get that scheduled. But talking about childbirth tonight, we'll have some images in here that are a little graphic, and I'll go ahead and preface that. But nonetheless, it's our job as medical providers to provide a modest type atmosphere for our patients. So this is one of those not so modest times where a female has her legs wide open and everything's for sometimes the pain is so intense they don't really care, and sometimes it's very embarrassing or whatever. So nonetheless, we try to be very adult about it and professional, and ensure that we're keeping a modest atmosphere for our patients. So again, it's a normal part of life. It's not it's really other than some of the complications, which we'll get to towards the end. It usually goes pretty smoothly. There's just certain things you want to try to make sure that you do for the baby's sake and for mom's sake, and barring any of those major issues, it's typically goes pretty well. So again, we're just kind of in our role as first responders, we're really just going to assist. We're not going to do a whole lot of invasiveness. So, but again, sometimes we're faced with that challenge, and there's nothing we can do about it. The baby's coming, and there's nothing anybody can do about that. So, there's just something we kind of get thrown into, and we'll have to assist as best we can. And we're going to talk about how to do that here in a little bit. So, big thing we want to make sure, just like we do with any of our patients, we've talked about over and over and over again, is making sure that they are breathing adequately and being kept warm, comfortable, that sort of thing. Their ABCs are accounted for, right? So that's the biggest thing. Frequency of contractions and crowning are indicators of impending birth. That's pretty consistent. Just a little bit of I know everybody's probably may have a different understanding of or different knowledge of what the female reproductive system is like and how it works, and so this is just a little bit of an overview of that. We're not going to get real deep at all into it, but again, as you read through your chapters and review these slides, just try to make sure you kind of understand what's going on inside there. The ovaries produce eggs, right? And so the egg travels through the fallopian tube to the uterus. Okay, so the uterus, or the womb where the baby is at, holds the fertilized egg as it develops during pregnancy. So that egg obviously gets fertilized and ends up becoming, the fetus. So the developing newborn is encased in an amniotic sac for support and floats in an amniotic fluid. Okay, so they're in a little sac in there in the uterus, and that's where they develop. So as you can see in the picture, they're not necessarily in this configuration the whole time. However, what we're not going to talk about all the different stages of child development. We're really focusing on the birth part. Okay, so the very end. All right. So, if we have somebody who is having some issues in an earlier term, right? So month 3 or something like that. Really, it's going to be about patient history and things of that nature, and that's really where we're going to be able to do anything about it. So, however, on the birth part, hopefully by that time they're going to give birth. The fetus should be in somewhat this type of orientation, head down. And they should start to have started to rotate in this configuration. And this is how they should exit. And we'll get into some of the issues arising when they don't exit in this configuration. Okay. But as you can see, you have the uterus there. The uterine wall surrounds the baby and enlarges. You have the placenta there, which is kind of like almost like a pie shape sometimes, and it's kind of attached to the uterine wall, which provides the nutrients for the baby, and it connects to the umbilical cord. As you can see there, that sac will kind of follow them out. So as they come through the birth canal, the vagina, they should have that should break. But if it doesn't, we'll have to do that for them. We'll get into that in a little bit. But that's essentially how the configuration should be. Okay. So the stages of labor, right? So not of development, but of labor itself. The first stage of labor for the pregnant woman's body prepares for birth. The initial contractions occur, right? So they start to feel that. The bag of water breaks. So again, that would be the indication of, hey, something's about to happen here. So again, as it starts to move into the birth canal, that should break. It doesn't always do that. The bloody show occurs. So anytime, a lot of times with child birth or pregnancy in general, blood is usually not a good thing. However, there towards the very end, where they're actually going to start labor, there will be some blood, and it's normal. Definitely after birth, having a considerable amount of blood is normal. The newborn's head does not appear during the contractions. Okay, it's going to take a little while for it to reach, the distal end of the vagina and start to actually present itself. However, and this is one of those things that will help you to understand what you're dealing with. Part of your patient assessment, when we're asking about, previous medical, instances, right? So we're talking about, hey, have you ever had, one of the big questions is, have you have any other children, and how many? Okay. How many children have you gave birth to? Right. There's obviously potential for, people, or for a woman to have lost a child for different reasons. And so, and to them it is, and to everyone involved, usually it is, that is still, their baby, right? But they didn't birth that baby. So you try to ask a more specific question: how many children have you gave birth to? Okay. So if that number is like 3 and 4 and things like that, more than likely this baby is going to come quickly. Okay. So expect that. It may not always be the case, but it is very common for that to happen. Okay. For them to come much more quickly than, say, a first or second time birth. All right. So be sure to ask these questions and know what you're getting into. So again, if they said, I've been having contractions for, 10, 15, 20 minutes or whatever, and you look down there and they're crowning, okay, the head showing, and they said, yeah, this is my 4th child or whatever, more than likely we're going to, we're going to be dealing with a baby pretty soon. Okay. So just be cautious of that. All right. So again, second stage of labor is the actual birth of the newborn. You'll see the newborn's head crowning during contractions. So as that uterus contracts, you'll start to see that the head almost kind of pulsate towards the vagina. The vagina will start to dilate, and that dilation is in centimeters. So it's gauged in centimeters. And so as the dilation occurs, is essentially the head just pushing the vagina open. And so as it gets larger, you can start to gauge about how much longer it will be. Generally, they'll be able to tell you, hey, I need to go right now. And if that's the case, a lot of times you don't have to do a whole hell of a lot. You just say, okay, let's go, let's get in the back of the truck and let's go. And that's generally the majority of the time, unless there's some type of issue where they waited too long, or they're at home, or they don't have any prenatal care, so they haven't been to the doctor very much, they haven't been doing what they're supposed to do, and then all of a sudden they just, are having the baby at home or something like that. They don't have a plan to go to the hospital or anything. They don't have a doctor that they've been seen by that's given them a plan for their birth. Then, you may have some other complications there. And the biggest thing is just about stabilizing mom and put her in a position of comfort, and having her work through her contractions by some breathing techniques, and get to the hospital as soon as you can. So if it's imminent, if birth is imminent, then we'll try to get as far as we can, but sometimes it may not be possible. So the third stage of labor, again, delivery of the placenta, the afterbirth, which is what I was just describing earlier. It's going to take about, it could be anywhere from about half an hour or so, just depends. And it's going to deliver after the baby. So, mom doesn't get to just, jump up and walk around, right? It's she's going to be there for a little while. And so once we get mom and the newborn stabilized, we need to be prepared to deliver the placenta. And especially if we are a little ways away from the hospital, it's going to be important because that is still connected to them. That has that is part of their blood supply. And so we don't want to, clamp that off and cut it and do all that sort of stuff without doing it correctly. So big thing, we want to make sure that we deliver that placenta and have it there. And we're going to talk more about that in a little bit. So like I said before, we want to ask them, is this their first pregnancy? And a lot of, like I said, more often than not, those will take quite a while. Could be several hours for a first time birth. And so it's one of those things we have to, I guess it's good for us that we have a little bit more time to deal with the patient before they actually give birth. But it's like I said, some people aren't prepared for that, and they may stick it out as long as they possibly can. And some people, for religious reasons or social reasons or whatever, may not want to go to the hospital. They don't want any drugs. They don't want all these other interventions and stuff until they get to the point of pain and discomfort that they weren't expecting, and they end up calling 911 or something, and then they really want to go to the hospital now, and so we have to go. But so again, want to ask, have they experienced any bloody show, and has the bag of water broken? Like I said, usually towards the end of the first stage of labor is when that's going to happen. So usually it'll happen anyway, and they'll tell you, my water broke. I was walking to the car, my water broke, or I was, whatever. So usually it's right there, but when they don't even realize it, and that's the first thing they experience. So how frequent are the contractions? Is the other question. So a woman experiencing her first labor will usually indicate the delivery will occur very soon, contractions less than 2 minutes apart will usually indicate the delivery will occur very soon. So, if you ask them about how far apart they are, they can kind of tell you. And that's where we're gonna start to make a transport decision generally. So does the woman feel an urge to move her bowels? And generally this is because the head is in the birth canal and it's starting to press against the rectum and the uterus. The ureters. And so you're starting to have, or the bladder, and it's starting to, put pressure against it. And that's just starting, just kind of a little heads up that, hey, this, the baby's actually starting to move down. Not a good idea to let her go to the bathroom. There have been plenty of babies that have been delivered in a toilet because of that. Just somebody not knowing what to do, and having that urge. And so whenever they have that urge, they feel like they don't want to be in some embarrassing position with their legs spread wide open, and then defecating on themselves or something. So, but nonetheless, generally that's not going to happen. So probably, not a good idea to let them do that. So if there's time to reach the hospital, we want to check and see if the newborn's head is crowning. Again, a quick look, see what the dilation is, see if there's any crowning. Yes, no, that's all we need to do. We don't have to go down there and expose it, all the time and all this other stuff. All right, have everything covered up. Take a quick peek, see what we need to look for, and then cover it back up. Right? Is the ambulance responding? If the ambulance is coming, we might be able to wait just a few minutes. If not, probably a good idea. Tell them to go ahead and put them in a vehicle, privately owned vehicle, and have them, go on to the hospital. Especially if their contractions aren't that far apart, or are far apart. Again, how far is it to the hospital? So, if we're way out somewhere, that may be another issue that we're going to have. Will bad weather, natural disaster, or traffic prevent prompt arrival of transportation? So again, all these different factors we need to take into consideration, and based off of our patient assessment, and see what that kind of shakes out, how those intersect. And if these questions are, if you're answering, no to all these questions or yes to some of them, as far as it's going to be a long transport time, or it's going to be, roadblocks in the situation are going to get in our way, then we're probably going to have to, think about delivery on site. So talking about time and contractions, the time the contraction cycles from the beginning of one contraction to the beginning of the next. And if the contractions are less than 3 minutes apart, delivery is close. Okay. So if they can tell you what it is, that's great. If you have enough time for where you can measure it, it's even better. And we might be able to get, again, if those are, 2 minutes, 3 minutes or less in that time frame, something's probably going to happen here pretty quick. But, if it's every 10 minutes or something like that, we got a little time and we need to go ahead and go. So detecting crowning, observe the vaginal opening during the contraction. If you see the head crowning during the contraction, prepare for delivery. Like I said, it's probably going to start to kind of pulsate in and out a little bit there. And that's definitely a sign that we're very close. Okay. So do not risk transporting the woman to the hospital. If you have crowning like that, you see the baby's head, just go ahead and prepare for that birth. So keep some things in mind here. Keep the mother calm. Delivery is a natural process, but it's painful. It's uncomfortable, to say the least. Not everybody is prepared for it, mentally and physically. So, you just have to do everything you can to try to, comfort them, keep them calm, keep yourself calm. Remember you're there to help, and it may be your first time to ever have to do that or see anything like that. And so, it's definitely an eye-opening experience. And, again, it's one of those things where we have to, just like a trauma scene or anything like that, right? We have to be there and be the calm in the storm. So it's understandable you're not going to be able to maintain sterile conditions, but we're going to attempt to keep the area as clean as possible. So, if you can, wash your hands thoroughly, keep your gloves clean as you can. If you don't have a sterile delivery kit, or if you have some type of sterile delivery kit, we want to use that. But if you have a sterile delivery kit that's encased in plastic and all that, try to use that and keep it clean. Clean towels, things like that. Like I said, there's going to be a lot of blood and fluid and everything else in that, whenever this goes down and then afterwards. So try to keep some clean towels, clean warm towels around, if you can. And that will make things a little bit more pleasant for everybody involved. So place the patient on a firm surface that is padded with blankets, folded sheets, or towels. It's a good idea if you have something, not necessarily roll a towel or blanket, but maybe fold it over several times and put it about 2 to 4 inches with pillows. Raise their hips up about 2 to 4 inches, and that again will kind of help elevate their hips to the point to where takes some of the pressure off their lower back. Place the woman on her back with knees bent and feet flat on the surface beneath her. Okay. So, like we said before, you need to. This is one of those times where, especially in these kits, these obstetric kits, they'll have a lot of times they'll have a gown and mask or goggles or something like that. Probably a good time to go ahead and put those on. Definitely right before we get ready to deliver. Like I said, use sterile gloves whenever possible, but face shield, eye protection, surgical gown, something along those lines is going to be a good thing, because like I said, there's going to be a lot of blood and bodily fluids being tossed around here, and it's just going to be something that you're going to want to do. These obstetric kits, like I said, are pre-packed. They usually have most of everything you need. In general, like I said, if you're using this and you don't have blankets and towels and all that sort of stuff, you'll need to get those from somewhere. But these kits have all the medical type stuff that you're probably gonna need. So sterile gloves, umbilical cord clamp, drapes and towels. It may just be a little thin paper drape that you just kind of drape over their knees, and their vagina in that area, just to kind of keep things covered up. Sanitary pads, which we'll probably need later on if they start to bleed too much. 4x4 gauze pads. Towel or blanket for the newborn. Bulb syringe is an important one. Plastic bag for the placenta. Once it delivers, we'll need to wrap that up, keep it warm, and keep it near the baby. Like I said before, sheets and towels for the mother, keep her warm as well. Suction, if you have some other type, if you don't have a bulb suction, then some other type of suction. Oxygen, you may need a newborn size face mask possibly as well. Not a bad idea for mom. She's going to be doing a little bit of hyperventilating at times, so it's not a bad idea to have her on some oxygen. If you don't have a delivery kit, look for appropriate substitute materials, but just like I said, you need to try to have them as clean as possible. So again, remember, there are 2 lives to be considered in this situation: the life of the mother and the life of the newborn. So, don't neglect the patient assessment on the mother. That's going to be the main thing, even if, she may be having as soon as you walk up, she's having contractions, right? So we may need to give her a minute, let her have her contractions, and let her calm down a little bit, and then we'll try to start asking our questions. But in general, we want to try to get as much information about the history of her pregnancy, and then also her medical history as well. Okay, so any issues that she's had before the pregnancy, and then any issues that she or the baby have encountered during the pregnancy. Your primary purpose is to assist in the delivery of the newborn. Like I said, if we're not having to deliver, then our primary concern is to keep the mother comfortable and transport to the hospital, and that's really all we're concerned about. So if we're not having to deliver the baby, there's really not a whole lot else for us to do besides that. So again, if we're assisting with the delivery, the newborn's head should emerge slowly to prevent undue stress on the newborn and tearing of the vaginal tissues. As the head emerges, support the newborn's head and tell the woman to stop pushing. They may have been instructed to do that. There may be something in their birthing classes that they've been told to push and all these other things like that. And at certain times they need to push and be encouraged to push. But after a certain point in time, once it's there, we need to have her hold off on that. So don't attempt to pull the newborn during delivery. So we're not, so even if the head is sticking out, we're not going to try to pull on it. Okay. The main thing with that is really about rotating the shoulders of the baby in a normal delivery. Okay, we're going to get to abnormal deliveries here in a minute, but in a normal delivery, the head may come out face down or face up, and we would prefer that to be their face left or right of the vagina, and that way their shoulders are more in line with the vaginal opening. Okay, and so we can have the shoulders exit a little bit more smoothly, which again will be the primary cause of discomfort for the mother. Okay. So again, the newborn will turn to its side by itself after the head emerges. But again, if it doesn't, we need to try to just coax it to the, coax the head around to the side. The rest of the body will be delivered spontaneously, and the newborn will be wet and slippery. So have a nice, good, clean, warm towel ready to catch them. So once the shoulders present, then they'll come out pretty quickly. Okay. So like I said, main thing is if that head is not down, the head is not sideways, we need to try to, gently just, with our fingertips, just try to, rotate them a little bit to the side. Won't take very much. Keep the newborn's head at about the level of the woman's vagina. So as you can see here, these pictures will come up. So as you can see in these pictures, so top left, we have crowning. Don't worry about putting pressure on their head and things like that. But we don't want to press hard at all, because remember that baby has a soft fontanelle there. And so as you can see in this one, their head is down, and we just want to cradle their head, and maybe with a couple fingers or whatever on the top and bottom, just rotate their shoulders a little bit. And we want them to be in this position they are in that fourth picture, where their head is to the side and their shoulders are starting to present. You may have to kind of go one shoulder than the other one, but ultimately, after it gets past that second shoulder, they'll usually come right on out. So the amniotic sac has, if it's not been broken, you want to tear it with your fingers. So there's plenty of pictures out there if you want to Google it, see what that looks like. It looks like a little alien. It's just it's literally like a plastic bubble with a baby inside of it. Okay, but ultimately what we have to do is if it starts to come out like that, if it starts to present like that, we're just going to tear it. Okay, just take two hands and reach up there, pinch it with two fingers, or with both hands, and just tear it. It's not that tough. Tear it open, and then move it away from the baby's face. Again, you're going to have a rush of water come out, or amniotic fluid. But like I said, that's what I was talking to you about. It's going to happen. You're going to have plenty of fluid everywhere, so just expect that. And if you can let one of those towels catch all that, clean everything else up, take that towel, remove it, put another towel in its place, and get ready for the baby. And so once we do that, we're going to make sure that it's away from their head and their mouth and their nose and all that, when they can breathe. And this essentially will be the baby's first exterior breath. Once the baby gets out, we'll talk about suctioning, but ultimately we're going to end up having to do that. So if the umbilical cord is wrapped around the neck, attempt to slip it over the head. So if it's nice and loose, but it's just around the neck, just take it and move it over the head. Not a big deal. If you can't disentangle the umbilical cord, try to just put your fingers in between it, spread it out a little bit, that sort of thing. But we don't want to pull on it. Okay. So we don't want to try to pull some slack from the inside. Okay. We don't want to do that. So this may be something where we constantly have to deal with that. And it's it's an unfortunate situation, but ultimately we're trying to keep it off the baby's airway. And then once it delivers, it'll probably be a little bit easier for us to untangle it. But ultimately that's how we're going to have to deal with that. So like I said, whenever the head presents and we deliver the baby, one of the first things we want to do is suction the baby's mouth and then their nose. So suction their mouth first and then their nose, all right, 2 or 3 times until they're clear. All right, so take that bulb syringe, just like a turkey baster, squeeze it, put it in the mouth, suction 2 or 3 times in the mouth, get all that amniotic fluid and all that other stuff out of the way, squeeze it, get it cleared. Same thing, squeeze it, put it in the nose, suction. All right, do that 2 or 3 times in each nostril and get all that fluid out of there. And by that time, they should be starting to breathe on their own. If we can, wrap them up, place the newborn on the mother's abdomen. Remember, we still have the placenta to deliver, so we're not, they can't. So depending on, we really just kind of depends on the length of that umbilical cord and how far we can bring the newborn. But we want to make sure that we we let mom know everything's okay and things are going good, and let her know what we're doing and while we're sticking stuff in there and in the baby and all this other stuff, right? So keep her updated as to what we're doing. All right, so that's kind of what it looks like. Like I said, just squeeze that bulb syringe, stick it down in the airway, and get as much as you can out of there. If you look down at the bottom there, that's the umbilical cord. So that's what it's going to look like. It's a big, thick cord. See, it has a lot of turns and kinks in it. So sometimes that just gets wrapped around the baby's neck. So if the newborn is not breathing, suction the mouth, like I said, and nose again, rub the newborn's back or flick the soles of the newborn's feet to stimulate breathing. Sometimes it just needs a little bit of a nervous system response to kind of, get that spontaneous breathing going. Again, this is the first time that it's ever breathed outside air. So it's the body's just not used to doing that yet. So we have to kind of jumpstart it. So use the towel to dry the newborn and then wrap him or her in a blanket to keep him or her warm. Again, we want to just try to clean them off as best we can, and then kind of swaddle them with their hands down and wrap them all the way up. So place the newborn on its side with the head slightly lower than the trunk. When the umbilical cord stops pulsating, clamp it with the umbilical cord clamps or tie it with gauze. There's a lot of different ways of doing this too. They talk about it, but again, when the cord stops pulsating, that's when we want to clamp it. And you take that clamp, excuse me, and put it on there, and then note that time of delivery. If there are multiple births, prepare for second delivery. Right. So again, they may be going off the same placenta or a larger one. So it's if they're twins or triplets or whatever it might be. So like I said, we talked about the placenta a little bit earlier. Never pull on the umbilical cord. It's going to directly pull against the placenta. And if you do that, you may have, you may make the bleeding worse, the afterbirth bleeding much worse if you try to rip that and the placenta off the uterine wall. So let it detach naturally and deliver on its own. So deliver the umbilical cord uncut. Let's see, uncut and attached to the placenta and the newborn until the EMS units arrive. So we don't want to, we can clamp it, but we don't want to cut the cord until we get the ambulance there. You guys seeing delivery of the placenta? These slides are taking a second. All right, there we go. All right, so after the placenta is delivered, we want to put it in a towel, something like that, with 3/4 of the umbilical cord, and place it in a plastic bag and transport it to the hospital. Try to keep it the same level as the newborn. Again, remember this is kind of part of their blood supply, and nutrients and things like that. So the longer it's connected and all that, just the better it's going to be. We don't want to damage that. And sometimes, again, culturally, religiously, things of that nature, the family may have plans for the placenta. So we're not going to discard it. We're not going to just cut the cord, throw it away, and all this other stuff. Some people are very, very strict religiously and social and culturally about the placenta and what's done with it and all this other stuff. So the mother's bleeding usually stops after the placenta is delivered. There may be a little bit that follows it, but if it doesn't, you want to try to massage the uterus, and we do that by placing one hand just above the mother's pubic bone, so just below the belly button in that area. Use your other hand to press down into the abdomen using a circular motion, again with the tips of your fingers or the heel of your palm, and just massage the uterus in a circular motion. Okay, it's not rocket science. You don't have to, you don't have to be a doctor. I know it may look weird for you to do that. Now, if you have a significant other there that may want to do that for you, hey, let them do it. No big deal. Give them a quick little instruction as to how you want them to do it, and let them do that. That may be a better of a connection for them to be able to do that, and a little bit less odd of a situation. But if not, again, just let them know what you're doing. Hey, yeah, you still have some bleeding. We want to try to control that. We need to, massage your uterus from the outside to try to slow some of that bleeding down. Okay, 3 to 5 minutes. See if that helps. And like I said, you just want to keep them updated as to what you're doing. So continue to observe the mother and newborn and keep both of them warm. Even so, like I said, her lower body's pretty much going to be completely exposed for quite a while, and it's usually cold in the back of the ambulance and all that jazz. So, want to try to keep it nice and warm. Keep a blanket on them. So about every 3 to 5 minutes, check the uterus for firmness. Recheck the vagina for any excessive bleeding. In a normal delivery, the mother will lose about 300 to 500 milliliters, 1 to 2 cups of blood. So just if you know what an IV bag looks like, the normal IV bag is about 1,000 milliliters. So it's it's about half of that, a little more than half of that. So it's one of those things we just have to, again, we're reassessing our patient, right? So about every 3 to 5 minutes, just kind of recheck everything, make sure we're not, again, bleeding excessively or anything like that, and then promptly transport. So again, like I said, continue to massage the uterus if it's not firm or if bleeding continues. You want to clean the mother with clean, moist towels or cloths, and give her small amounts of water to drink if she's thirsty. So just a little bit, have her sip it here and there. We're not trying to let her just guzzle down it, which, I mean, like I said, depending on how long it's taken, she's going to be very tired and exhausted and that sort of thing. So it's understandable, but we don't, again, depending on what's going on, there could still need to be surgical interventions depending on what happens, and we don't want them to drink a whole lot. So resuscitating the newborn. If the newborn does not breathe on its own within the first minute after birth, proceed, which we'll talk more about that. But it's essentially your infant CPR. And so we're going, like I said, we're going to try to tap the feet, massage the back, things like that. If that doesn't work and they don't spontaneously start to breathe after we've done those couple things, then we're essentially going to have to start our infant CPR type protocols, right? So same thing we would do for anybody else. If they're 30 minutes old or 30 days old, we're going to do the same thing. So ectopic pregnancy and shock in a pregnant woman. The ectopic pregnancy essentially is when the fertilized egg is is still in the or gets implanted in the fallopian tubes, and essentially it starts to grow inside there, and it can't get out, so it doesn't make it to the uterus. It gets trapped in between in the tube, and that tube the embryo starts to grow, and then it expands, and the fallopian tube ruptures. All right, so again, usually very painful. A lot of times they'll experience that, kind of uncommon abdominal pain, intense abdominal pain, potentially some bleeding, things like that. And they'll, more than likely that's when we're going to get called, and then they'll get transported, and then they'll have to get diagnosed at the hospital. But that's one of the things that will be, you can consider if that happens. Like I said, it could have some internal bleeding and potentially shock. So we're going to look for those types of issues in our patients. If they're complaining of those signs and symptoms, then we're going to be looking strongly at their blood pressure and pulses and things like that, and look for those signs of shock. Treat them for shock if they do have that, and arrange for prompt transport. And that's really all we're going to be able to do. Of course, O2 depending on their oxygen saturation. All right, so miscarriage and vaginal bleeding. Of course, miscarriage is always a possibility. Spontaneous abortion, essentially, is delivering an incomplete or underdeveloped fetus. If a miscarriage occurs, save the fetus and all the tissues that passes from the vagina. Control the woman's bleeding and treat for shock, just like we talked about before. After as far as any uterine massage, or placing some sterile dressings up against the vagina, things like that, and arrange for prompt transport. Big thing here is keeping the mother and family in general, try to keep them calm, and give them some type of emotional support, and as best you can, right? And then transport them as accordingly. But it's often the predecessor is going to be some bleeding, so maybe spotting, things like that, and that's generally why they may call. So we want to obtain a good patient assessment. Like I said, we want to try to understand what's been going on. Maybe did something happen? What were they doing? In the time previous to this, and that may give us an idea of why the miscarriage happened, or help the medical staff reach a conclusion later on. Good set of vital signs. Again, arrange for prompt transport, and like I said before, arrange for provide that emotional support if she did actually miscarry. So premature birth, any newborn weighing less than 5 pounds or delivered before 36 weeks is premature. Premature newborns are smaller, thinner, usually redder than a full-term newborn. You want to keep these premature newborns warm, just like we would all babies. But again, they are more susceptible to heat loss, so try to keep them nice and wrapped up and warm. And transport immediately. Again, not a whole lot else we're going to be able to do for them in the field, but it's just something that we want to make note of. If they're obviously, and mom may know it already. They may know that they're have a small stature or low birth weight or something like that. So may not be a surprise to them, but if it is, again, same thing. Just try to keep all the ABCs intact, and assess all those things right off the bat. Reassure mom that they're breathing, and that we'll do everything we can, and we'll get to the hospital quickly, and we'll see what they can do, So just one of those things to be mindful of. So, unbroken bag of waters, like I said before, if it happens to not have broken by the time it gets to birth, we're just going to reach up there and tear it, and try to get the mouth and the nose, or get the bag away from the mouth and the nose so they can breathe. Of course, we're not just going to stick our fingers in there willy nilly. So just try to grab the bag in an area that's not going to injure the baby. And like I said, as soon as we do that and we get all that fluid out of the way, then we'll start suctioning the mouth and then the nose. So prolapse of the umbilical cord, where the umbilical cord is coming out first, that's a potential, or it's, like I said, it's wrapped around the baby's neck. But predominantly what we're talking about is the cord being compressed between the newborn and the woman's pelvis during contractions. Generally, we try to place the female in a position that raises her hips, okay, and then keep the cord covered and moist, and do not try to push it back into the vagina. So ultimately, the cord will come out before the baby does. All right. So like I said, if that does that, like it says, keep it moist and covered, and moist cloth or clean cloth, and don't push it back in there. If need be, you can administer O2, arrange for transport. It says some EMS systems recommend placing the woman in a kneeling position to take the pressure off the cord. This would be one of those where I would just get with the ambulance. If they're not already on scene, I would tell them what you got, see what they want you to do. They're probably going to have you just stay in that position, raise your hips up some, and take the pressure off the try to help take the pressure off a little bit by doing that. But you don't see them doing the kneeling position very much. Breech birth, this where any other part of the baby is presenting other than the head. So in this case, it'd be the buttocks, the arm, the leg, something like that, is coming out first. Okay. So big thing, arrange for prompt transport. Not a whole lot we can do in the field. If the buttocks and the legs are delivered, we're going to try to just support them as best we can. We're not going to push it back in, anything like that. Like I said, there's just not a whole lot we're going to be able to do. And we'll try to let it, see if it'll work itself out. And so if that head doesn't deliver in 3 minutes, we want to try to keep the baby's head, keep their airway open, so inserting a gloved hand into the vagina and use your fingers to keep the newborn's airway open. It's kind of an iffy thing to do. You really need to be able to articulate why you did that. So if you do happen to have to do that, you have a breech birth, you have some limb that's out, and you can articulate that, and that there was an absolute need for you to maintain the newborn's airway, then sure, go ahead. But you need to make sure that you articulate that in your report that you did that. Okay. Again, that's a very rare case, but again, you need to make sure that you document that thoroughly. So a stillborn delivery, similar to a miscarriage, potentially. Again, they may know it and they may not. That essentially the newborn dies in the uterus before labor. A lot of times when this happens at this stage, there's going to be a pretty unpleasant smell. It's a pretty bad smell, and they won't show any signs of life. Their color will be different. They, of course, won't be moving or anything like that. So, just like with any other deceased person, we want to, give great care and modesty to the body. And, like I said, just depends on the situation. They may be expecting it. And if they're not, it's going to, it's still going to be devastating, but if not, it's going to be even more so. So, again, try to turn your attention to the mother and provide, some of that emotional support. Again, there still could be bleeding, still be, fluid, things like that. So, just the same thing as any other pregnancy. Labor. We're going to monitor that, and if they want them to be covered up, cover them up. If they want to be able to see them, we'll let them see them. It's their child. So, of course, we're going to let our, med control or the EMS, we're going to let them know immediately what we have and what's going on. So what everybody, looks forward to is multiple births. So if, doing it once wasn't enough, we may have to do it multiple times. So, again, another set of labor contractions will begin shortly after delivery of the first newborn. And so we're just going to get ready to repeat the same procedures that we just did for the first one. Get everything out of the way, clean them off, suction, do all that sort of stuff, and then get them wrapped up and nice and warm. Let mom hold on to them, or somebody close by, maybe, or we have to set them off to the side in a nice safe area on some towels or something, so that we can get our hands free to be able to do number two. All right. Again, excessive bleeding after delivery. It's common for them to lose 1 to 2 cups of blood during normal childbirth. So, again, that placenta is going to be a little bit larger potentially in this case, and so we're going to have a good bit. So we talked about this earlier. Again, monitor for shock, place some, sanitary pads over the vagina and help to absorb some of that. And again, give some massage to the uterus from the exterior. It says encourage the newborn to nurse at the mother's breast. This may be a possibility. Maybe a little bit later on after we kind of got everything done, that might happen, but not commonly in the field. Massage the uterus with your hand, like I said before, and if the area between the mother's vagina and anus is torn and bleeding, treat it as you would any other open wound. Okay, they call this an episiotomy. Sometimes it's surgically done for the mother's benefit. And sometimes it happens just because the child's large. It's a large child, and it's just too big for the vaginal opening, so it may rip or tear. So again, just like any other avulsion or a cut or anything like that we would treat, we're going to apply pressure, gentle pressure, and with a clean, sterile dressing, and we may even try to put put a towel in that area or something like that to help keep just gentle pressure against it, and hopefully that bleeding will be controlled. But ultimately, we're going to have to again keep it as clean as we can, so we don't get it infected. All right, so talking about vehicle accidents with pregnant women, that's definitely something that nobody wants to have to deal with. It does happen, unfortunately, and we're always concerned about complications because of that. The woman needs to be examined by a physician afterwards. Or just no two ways about it. Again, we can't force them to do that, but we want to, remind them, hey, it's a good idea if you go to get checked out. It doesn't take a very significant crash to damage something internally. So with the child, the unborn child, so it's best that they go get examined. So again, try to arrange them for transport and get them to a hospital pretty quick. So again, if they start to exhibit signs of shock, monitor the airway, breathing circulations like we would any other patient. High flow O2. Have the woman lie on her left side rather than on her back. Help take some of the pressure off of the main vessels and things of that nature. In rare cases where the crash is so severe that it kills the woman or the mother but does not kill the fetus, it is still, we're going to provide CPR and that, that ACLS algorithm to the mother so that we might be able to save the child. And again, we don't know. We don't know what's going on internally. We don't have ultrasound out there. We don't have all these other things to be able to monitor the baby. So we need to try to keep the mother as viable as possible until we know whether or not, the baby is viable. So we'll do everything we can to keep the mom alive until we can get them to the hospital. All right, so not a long chapter tonight. Like I said, there's a lot more that goes into childbirth that we deal with in EMT and paramedic and stuff like that. A lot of other, we get way deeper in a lot of these other situations that we've talked about. But it's one of those things, again, you can't really practice for it very much, but we try our best to, like I said, comfort the mother, keep everybody comfortable, warm, that sort of thing. Kind of see that theme running through there. Clean is the other big one, and ensure that we are, transporting promptly if we have that opportunity. So if those contractions are far enough apart, hey, let's load and go. All right, we can talk about all the other stuff in the ambulance. If they are wanting to load up and go in a car or something like that, I wouldn't stop them. I would have somebody ride with them just in case they can, call or whatever. But if they are close enough to the hospital and they want to go ahead and go, and you arrive on scene and they're loading up to go, I wouldn't stop them and wait. Okay, so try to get some information really quick and let them be on their way. But if those contractions are pretty close, it's probably going to be, like I said, 2-3 minutes. It's going to be something we're probably going to have to end up dealing with. They're probably not going to walk. They're probably not going to want to move very much. So, like I said, keep it simple, keep it clean and dry and warm, and you usually are going to be okay. And if those other situations arise, we'll have to deal with them as they come. But does anybody have any questions on any of that from tonight?
No, I'm supposed to be getting a book tomorrow. Let you know.
Okay. All right. Good deal. Sounds good. Good deal. Again, if anybody has any other issues or questions, concerns, please reach out and let me know. Like I said, we're right here at the end. So let's do what we need to do to get those quizzes done and all that good stuff, and we'll knock this thing out.
Sounds good.
All right, good deal. Thanks, guys. See y'all later.
All right.
Is there a class number?
Oh, I'm sorry. You're right. So class number is going to be R0012, R0012.
All right.
All right, thank you.
Good deal. All right, thanks, guys. Appreciate it.